particular topic also. So, these are the topics which I am going to cover in the next few of my slides. The topic given to me was an approach to cyanotic congenital heart disease in neonates. I will be extending my talk to infants and little bit of grown up also. So, congenital heart disease is a structural abnormality of the heart and great vessels occurring during fetal development. So, generally we classify as acyanotic and cyanotic heart disease. My focus is be on cyanotic heart disease with decreased pulmonary blood flow and mixed pulmonary blood flow. So, the etiology is multifactorial with some syndromic abnormalities association and environmental risk factors also associated with this. So, in fetal circulation, we know that the gas exchange occurs in the placenta. The oxygenated blood travels through the umbilical vein into the IVC through the ductus venosus, and from there a certain amount of blood shunts through the foramen ovale, and then certain blood goes from left atrium into the left ventricle into the aorta. So, this is how it is, and so cyanosis is basically caused by persistence of fetal circulation, right to left shunting across the foramen ovale and ductus arteriosus in the presence of an outflow tract obstruction at the pulmonary, or at the it can be due to a persistent pulmonary artery hypertension in the neonate. So these are the few clinical presentations: irritability, decreased level of activity, diaphoresis, crying with feeding, and history of longer time per breastfeed, poor weight gain, fast and irregular breathing, bluish or purplish discoloration noted by the mother. So cyanosis, tachypnea, increased work of breathing, pulmonary edema, tachycardia, heart murmurs, hepatomegaly, especially in obstructed TAPVCs, weak femoral pulses presenting with shock and lethargy. So classification is like, early in the first week, 7 days to 28 days, and beyond 28 days. In the first week, we think about most commonly of a transposition of great arteries, whereas there is a balanced mixing, pulmonary stenosis with intact ventricular septum, or pulmonary atresia with intact ventricular septum, HLHS, severe form of Epstein's, and obstructed TAPVC. Beyond a week, we have truncus TAPVCs, TGA with VSTs, and classical TOF, and usually tetralogy of Fallot and TGA with large ASDs presents beyond a month time. So basically, an approach to a congenital heart disease, we think about only two things. One is whether it is a duct-dependent pulmonary circulation or a duct-dependent systemic circulation. So when we are thinking about duct-dependent pulmonary circulation, patient presents with severe cyanosis, tachypnea with distress. This is basically because of two things: either because of critical pulmonary stenosis or pulmonary atresia, or at a balanced mixed shunting at the level of atrium in TTGA. So if it is a systemic circulation, presents with heart failure, poor perfusion, especially in hypoplastic left heart, critical CoA interruptions, all those patients present the latest stage with cyanosis. So cyanotic congenital heart disease based on pulmonary blood flow, either it is a decreased pulmonary blood flow, we have the TOF physiology, pulmonary atresia, VSD, DORV, tricuspid atresias, and Epstein's anomaly. With increased pulmonary blood flow, we have the TGA with the VSD, truncus, DORV without PS, TAPVCs, truncus, and single ventricle physiology. So based on the pulmonary blood flow with hypertension, we have low pulmonary blood flow in tetralogy of Fallot physiology, with increased pulmonary blood flow in transposition physiology. Then we have the pulmonary artery hypertension beyond the infant or childhood, where we have the Eisenbinger's. Obstructive TAPVC's presence earlier in the neonatal period with cyanosis. So this is how we screen a child presenting to us with the cyanosis. So less than 90%, 90 to 95%, more than 95%. More than 95% we know that it is not of a cyanotic heart disease. Less than 90%, we have to keep screening every year. Somewhere between 90 to 95%, keep on screening it. Once the screen fails, if it is less than 90%, we have to label it as cyanotic heart disease. If it is more than 95%, I think we have to think about acrocyanosis and then send the baby for observation at home. So these are the investigations we are interested in. Heart diseases being detected as early as the fetus. We have the pulmonary pulse oximetry screening. So any child with the saturation less than 85%, we put them on 8 to 10 liters by hood of oxygen. If the saturation goes above 85%, then ABG is done. If the ABG PaO2 is more than 150, it rules out predominantly a cyanotic heart disease. If it is less than 150, strong evidences for a cyanotic congenital heart disease has to be evaluated with a chest X-ray and a two-dimensional echocardiogram. So we have certain features of cyanotic heart diseases by X-ray. We have the egg-shaped heart in classical of TGA, snowman appearance in TAPVC, boot-shaped heart in tetralogy of Fallot, extreme form of cardiomegaly in Epstein's anomaly. So echocardiography will definitely give us a clue from where we're dealing with. So this is the child with the X-ray findings of a boot-shaped heart, and here we could see a still picture showing a very large ventricular septal defect, 50% aortic override and septal hypertrophy, very suggestive of a tetralogy of Fallot. So certain ECG findings. So to just concentrate on this V1 and V2, normally we have a sudden transition which we see this very typical sudden transition is very hallmark of tetralogy of Fallot with right axis deviation also. So here is a X-ray of transposition of gator arteries showing on an egg on end appearance. So especially when a neonatal ECG is being taken with a complete heart block, to think about corrected TGA. Here we could see two things. One is a Q in V1, so absence of QAs in V6 again, and presence in V1 suggests congenital corrected TGA by an ECG. So this is an X-ray finding and echocardiographic finding of a tricuspid atresia. So here we couldn't see the tricuspid valve. The RV is very small. There is a large conotruncal VSD. It's suggests the LV is of normal size, which all suggest a tricuspid atresia. So this is one ECG which is very important compared to the other cyanotic heart disease, because where there is no RV forces, predominantly we have RV forces in predominant heart disease, cyanotic heart disease. Here it is with a left axis deviation and a left ventricular hypertrophy. So this is a child with a very large heart. Whenever we have very large heart in chest X-ray, there are only three conditions. One is Epstein's anomaly, other one is a pericardial effusion, and third one is probably a dilated cardiomyopathy. So this is called a classical box-shaped heart of an Epstein's anomaly. So this is one of the child recently came to me with Epstein's anomaly. See, this is the sail-like pattern of the septal tricuspid leaflet with the severe tricuspid regurgitation. This tricuspid regurgitation is the cause for the JVP elevation. So this is one of the child which has been taken up for surgery. So the ECG findings in Epstein's anomaly, we have a tall broad P waves because of atrialized RV. Predominantly there will be a first degree AV block because of the large right atrium, right axis deviation, and pre-excitation is seen in 30 to 40% of the children with Epstein's anomaly. So next is the total anomalous pulmonary venous return. This is one of the commonest seen in the early newborn period if it is an obstructive. So we have the pulmonary veins draining into the right side of the heart instead of the left. And there are some few ECG findings which are not very hallmarks, but definitely a right axis deviation and a right ventricular hypertrophy indicates that we are dealing with some sort of a total anomalous pulmonary venous return. So we have two X-rays here, one showing a snowman's appearance because of a supracardiac TAPVC, the other mimicking of a hyaline membrane disease. Whenever we have a chest X-ray, something like this, we have to think about obstructive TAPVC also. So this is a 28 days old baby. You could see here the dilated right atrium, dilated right ventricle. The blue jet is the tricuspid regurgitation. This is the coronary sinus which is dilated. This coronary sinus dilatation indicates that there is a coronary sinus TAPVC. The other one, this is the blue flow, is the AST which is shunting right to left causing severe cyanosis. So this child underwent total correction within a few days and got corrected. So this is another picture showing dilated coronary sinus. Sometimes it will be missed as an ASD also, but this is the dilated coronary sinus. Look at the pulmonary artery hypertension. It is 100 millimeters of mercury in a 28 days old neonate, indicating that it is a obstructive TAPVC which needs an early correction. So this is another child with truncus arteriosus. You could see a large subarterial VSD. So we could see biventricular hypertrophy. This is the right ventricle, this is the left ventricle, this is the septum. This septum shows a hypertrophied ventricle, and this is the RPA and the right pulmonary artery and the left pulmonary artery arising from a very single trunk, indicating that it is a type 1 truncus arteriosus needing an early surgery. So coming to the management of cyanotic congenital heart diseases, medical management involves oxygen, and whenever there is a duct dependent circulation, oxygen has to be disconnected and started on prostaglandin infusion. Two procedures which could save the child is one is balloon-atrial septostomy and other one is ductal stenting, and obviously the palliative surgeries are BT shunt and the Glenn procedure where the venous circulation is connected directly to the pulmonary artery. So this is the algorithm to approach neonate with congenital heart disease. My focus is here on cyanosis. Here we have cyanotic heart disease with right-sided obstructive lesions, and we have other diseases like that obstructive TAP, pulmonary venous connection abnormalities, and truncus. So once this is done, needs a cardiac evaluation to see how we are going to proceed with. So two procedures which could be life-saving in a neonate with a duct-dependent circulation as well as with a mixed physiology, the balloon-atrial septostomy. So here we have some indications for balloon-atrial septostomy. This is one child which presented a couple of months ago. This is a detransposition of great arteries. Usually balloon-atrial septostomies are nowadays done on the bedside, but it is better to do under the fluoroscopic guidance. So DTGA with intact interatrial septum we do a balloon-atrial septostomy for a better mixing. Then we have the pulmonary atresia, tricuspid atresias. We have the hypoplastic left heart. Then so based on this, a prostaglandin infusion is being started, and then once we open up the duct, it is then taken up for these type of procedures. There is another. This is another child which presented to us a couple of. This is on 25th. This is a couple of weeks ago. This is we could see a very large VSD, 50% aortic override. In the right side of the screen, we could see a closing ductus with lot of turbulence. So this is the PDA which is getting closed. So we started on prostaglandin infusion and taken up for a procedure. So this is what is. So I took this child on day 3rd of life. So this axis is from the left subclavian. So a left subclavian sheath is being placed through the left subclavian axis. A guide wire is being placed into the ventricle, and from there you could see in the other part of the slide stent is being placed. So this stent is deployed to ensure that there is a mixing happening at the pulmonary artery level. So this is ductal stenting in a child with tetralogy of pulmonary atresia. This is for a palliation for few months, so that at 6 to 9 months of age the child goes for a corrective surgery. So this is the post ductal stenting picture showing a stent in the pulmonary artery with good flows into the right pulmonary and left pulmonary artery. So thank you for the patient listening. So my take-home message is identifying a cyanotic heart disease in the newborn period is once when you have a saturation less than 85%, do a hyperoxia test. If keeping 8 to 10 liters of oxygen by hood, if the saturation goes above 85%, then it is fine. If it is still continuing to be less than 85%, take a blood gas analysis. If the partial pressure of oxygen is less than 150, he goes for the cardiac screening. If it is more than 150, it can be observed, goes for the proper screening test. The second thing is there are two conditions which needs an early intervention. One is transposition of great arteries with an intact atrial septum, where balloon atrial septostomy definitely helps for a better mixing and a better saturation for a future corrective surgery. The other condition is a duct-dependent pulmonary circulation or a systemic circulation, where by starting on a prostaglandin infusion, we get a better saturation by giving a better oxygen supply to the pulmonary arteries. So ductal stenting makes the baby having a better saturation. Prior to it, an oxygen has to be definitely stopped because oxygen has a tendency to close the duct. So once that is done, baby can be taken up for a corrective surgery after 3 to 6 months of age. So this is how approach to be for a cyanotic heart diseases. The one other condition where it needs early intervention is directly for surgery is obstructive TAPVCs. The commonest obstructive TAPVC is a cardiac type TAPVC. We classify it as supracardiac, cardiac and infradiaphragmatic. Almost all infradiaphragmatic TAPVCs are obstructive, needs an early surgery. Cardiac type TAPVCs which I showed here are 30 to 40% are unobstructive, remaining 60% are obstructive, needs early correction, have a good quality of life from there on. Supracardiac TAPVCs are mostly unobstructive. We detect it with a minimal cyanosis and probably goes to beyond the infant and or childhood for a corrective surgery. With this I conclude my talk. I'll be open for discussion.
Thank you, sir, for the excellent talk. Give a round of applause.